Okay, so now we're going to have a look at how to assess the hip and groin area of the body. A notoriously difficult area to assess, so we're going to see if we can break it down into sections, try and make it a little bit easier and nice and quick for you as well. First things first, we need to ensure that we clear all red flag pathologies, all sinister pathology with our red flag questioning, which you can find on the website. First part of this assessment, we're just going to clear the back with some simple range of movement exercises. For our full back assessment, do see our back assessment video, which will take you through a full assessment here. So first thing we're going to do here is, if we get Rob to turn and face the other way for me. Okay, we can have a look at the back, make sure there's sort of nothing stand out that we can notice. We can check our levels as well. And then what we're going to do is just get Rob to bend forwards for me, go down as far as you can towards your toes. Good, and then come back up. And what we're looking for is any change of symptoms. Does it get better, worse, or stay the same? Okay, and then what I'm going to get you to do is just pop your hands on your back side and just have a lean back for me as far as you can. Good, and come back up. And again, does it get better, worse, stay the same? Now if you just want to slide your hand down the right hand side for me. Good, and then down the left. So we can have a look for any asymmetries, and again, does it change the symptoms at all? Okay. Once we've cleared that, we can go into our hip assessment. Be aware of sort of subjective markers as well. Is the pain more surrounding the back? Does the pain travel below the knee at all? They're a little bit more indicative of spinal pathology as opposed to hip. So we'll take it as we've cleared the back. There's no red flags, no sinister pathology. We're going to try and quickly and efficiently assess the hip. Okay. So the first thing I'm going to do is we're going to get Rob to come and have a lay on his back. Okay. So the first thing we're going to do is we're going to have a look at the range of movement at the hip. Okay, so all we're going to do is just ask Rob to take his leg up as far as he can, knee to chest. Good, and then come back down now. Good, and then keeping the leg straight, we're just going to take it out to the side. Good, and back in. And then if we can just bend it up again for me to about 90 degrees, lovely. I'm just going to get you to turn your leg inwards for me. Good, and then outwards. Good, and relax down there, lovely. And obviously we'll check the other side, compare the range of movement there. If he's got that sort of active range of movement, then we can probably consider there's not too much of a structural pathology in there. If that range of movement was restricted, we would then want to test it passively. Okay, so that would mean taking hold of the leg and just taking it through its range of movement. So we're just going to take it into flexion there, and what you're feeling for is, does it reproduce the patient's symptoms, or is there a stiff end range of movement at all? Okay, and then we can take it out to the side as well, and then up in this position we can test medial rotation and the lateral rotation as well. Sometimes a nice little check to quickly clear the hip of a sort of an arthritic hip structural pathology is just in line, just to medially rotate the hip like so. If active range of movement and passive range of movement is restricted and it brings on the patient's symptoms, then we can query a structural pathology such as osteoarthritis. In this situation, what we need to do is send the patient for an x-ray, and then if moderate or severe arthritis is established within the hip, we can refer him onto our structured hip assessment pathway. If, however, sort of mild arthritis is established, then refer him straight through to the normal physiotherapy services. The patient can obviously self-refer themselves as well. So if we've got our active range of movement and we've got a passive range of movement, and they're full, but they might be a bit painful, they might be a bit clicky, a bit clunky, then what we're still considering a structural pathology of the hip, maybe a labral tear or a femoral acetabular impingement. So what we're generally looking out for there is the pain associated with some clicking, some clunking, Do they get pain on sort of rising from a chair, that sort of thing. Objectively, they might sit in a bit of abduction and a bit of external rotation just to try and ease that hip joint there. Okay. Nice little check for that is what we call a fade test. So we're flexing, adducting and internally rotating the hip. Okay, and we can do that passively. We take the leg up and we take it across, and then we take it inwards into internal rotation. So we're really winding up that joint, looking for any of the patient's symptoms. Does that produce any pain? Okay. If it does, they may have a structural pathology in a labral tear or a femoral acetabular impingement. Okay, so to differentiate between the two, a labral tear or a femoral acetabular impingement, it's going to be more your subjective markers. So with a labral tear, you're looking at more of that sort of deep anterior groin pain, whereas a femoral acetabular impingement will be more of a kind of C shape around the hip there, sort of buttock groin area. Also, sort of labral tears will almost definitely be associated with clicking, clunking, popping sensations, whereas acetabular impingement may not. And with a labral tear, the patients will often stop them dead in their tracks. They won't be able to carry on, whereas with a acetabular impingement, they can often work through it. So if we've cleared all that, active range of movement, passive range of movements, all full, pain-free, the hip joint feels good, no restriction, no pain produced. What we then need to do is look at the sort of muscle structures around the area. Okay, so if we start with the groin, so we're looking for sort of pain within the groin area. A nice way of assessing that first is we're just going to have a look at the active range of movement of abduction and adduction. Okay, so if we consider the right leg here, what we'll do is get Rob to take his leg all the way out to the side as far as he can, and then all the way across his body as far as he can. Good, and again for me. And you can just get them to repeat that a few times, try and fatigue the muscle a little bit. Good, and relax there. And if there is a groin injury, whether that be a strain from an injury or a tendinopathy from overuse, then that will more than likely bring the symptoms on. What we can also look at is an abdominal flexion. So if I get Rob to bend the knees up and pop your feet on the bed for me, and you're just going to do a sit up for me. Okay, so if you want to just come up, good, and then back down for me. So again, we're contracting all the muscles within the abdominal and groin region there, and if we're producing any pain, we can then manage and treat the groin area. And then if you just straighten this leg down for me, we can stress the groin structures by stretching them passively. So just let me take you out to the side, putting them on, stretch through there, taking them into abduction. And then the final thing to assess the groin is we're just going to have a palpate along those structures. Okay, so coming onto the adductor muscles, see if you can reproduce any pain along the muscle tendinous junction, and then we can have a little feel through sort of the pubic area as well, just see if we produce any pain. That's the groin. Final thing in the hip assessment is whether the patient's getting any lateral hip pain. So lots of changes around sort of lateral hip pain in sort of current years. We used to consider it as a sort of bursitis sort of pain. However, more current research, more current literature tells us that actually it's a tendinopathy. It's the gluteal medius, gluteal minimus tendinopathy, which sits below the IT band and essentially gets compressed. So if the patient's getting lateral hip pain, pain above the greater trochanter, then we can consider this. A couple of nice little objective markers for it. What we can do is we can do the Fader test, which is flexion, adduction, and then external rotation. Okay, so we're winding up the lateral structures over that gluteal tendon. Okay, if that and we're looking for whether that produces pain. Second thing, if we get Rob to lay on his left side for me, what we want to do is do a resisted movement of the lateral structures there. So if you straighten your legs right out for me, all we're going to do is get them to come into abduction. So if you lift your leg up to my hand, keep it there for me, don't let you push you down. Good, and relax there. And again, we're assessing whether that reproduces any pain, and we're also looking for weakness, so you want to test both sides. And the final thing is you just want to palpate above the greater trochanter there. Okay, so we're looking over that kind of gluteal tendon area. Does that reproduce their pain? Other subjective markers will be like they can't lay on this side, they have difficulty when they cross their legs, when they're going up and down stairs, when they're walking and things like that. Good, so just to summarise, assessing the hip, we want to clear the back first, clear any red flag or sinister pathologies. We want to screen for arthritis, obviously taking subjective markers such as their age and aggravating factors, but do that by looking at active and passive range of movement. We want to screen for other structural pathology such as a labral tear or a femoral acetabular impingement. So again, we're looking at the integrity of that joint. Is there any reproduction of the symptoms through passive movements? And then we want to assess the groin. Okay, so we're assessing muscle structures, so we want to contract them and put them under strain and have a bit of a palpate of those structures. And then if it's lateral hip pain, we need to consider a gluteal tendinopathy. Okay, so we're assessing the lateral structures there, palpating, stretching and stressing those and putting them under contraction as well. With all of sort of the groin pain and the lateral hip pain, manage the patient's pain medication, advise them on any aggravating factors, and get them to self-refer to physio as soon as possible. These things tend not to get better without structured rehabilitation.